So the next topic in cardiovascular system is angina pectoris. We know angina is characterized by chest pain, and the reason of chest pain is less supply of blood to the heart. There are two main types of angina. One is called classical angina. Classical angina, also called exertional angina. Second type is called variant angina. The other name is Prinzmetal angina. And third name is vasospastic angina. Now, first of all, pathogenesis, how the angina occurs. Now, in classical angina, this is suppose heart which is supplied by a coronary artery. This is a coronary artery. Coronary artery divide in branches, which further divide in branches. So in classical angina, mostly it occurs due to atherosclerosis, which affects mostly the small branches of coronary artery. Now, because obstruction has occurred in this small branch, so there is less amount of blood which can come in this area. So when less amount of blood comes in this area, so this area is at risk of ischemia. But problem is, obstruction is present permanently, but pain in a patient of angina is not present 24 hours. Pain is only present sometimes. So when the obstruction is always present, why the pain is not always present? The answer to this also is same. That means body has compensatory ability for everything. So whenever the obstruction occurs, that lead to ischemia. And remember, ischemia itself is the most powerful vasodilator. So whenever the obstruction occurs, so that will lead to dilation of this artery. So ischemia lead to vasodilation. Ischemia lead to vasodilation. So this vessel will dilate so much that the effective diameter through which the blood goes, it will become just like a normal vessel. Normal vessel. So same amount of blood can go in this area as is coming in ischemic area. So when normal amount of blood is coming, there will be no pain. But important thing, suppose this person exercises or the work of heart increases due to any reason. So heart of this person will require more blood. So how the blood supply is increased is by causing vasodilation. If this area requires more blood, vessel will dilate here. If this area require more blood, vessel will dilate here. But if this area require more blood, now the vessel cannot dilate here because it is supplying the normal blood due to vasodilation. So if more blood is required, it cannot dilate further. So only during this time the pain will occur. So that's why the term classical angina, the other term is exertional angina. So in classical angina, the pain occurs only during exertion. So when the work of heart is more, only that time the pain will occur. So based on this pathogenesis, the treatment of classical angina will be to decrease the work of heart. Remember, there are two main methods to treat angina. One is to increase blood supply of the heart, and second is to decrease the work of the heart. So we cannot increase the blood supply because already the vessel has already been dilated. We cannot further dilate this vessel. So only thing we can do is decrease the work of heart. So most of the drugs which are used in classical angina, they are used to decrease the work of the heart. On the other hand, in variant angina, the main pathogenesis is it occurs due to vasoconstriction or spasm of the main coronary artery. Spasm of the main coronary artery. That's why the term is vasospastic angina. So when there is spasm, that means no blood can come in this area. So when no blood can come, so no work can be done. So that means in variant angina, we have to dilate the coronary artery because no blood is coming. So pain can occur even during rest. So if a person is having chest pain at rest, that is characteristic of variant angina. So based on this pathogenesis, the only treatment is to dilate the coronary artery. So all the drugs which are used in variant angina, they act by dilation of coronary artery. So that is the pathogenesis of angina. Now we can discuss the drugs used in angina. So important group of drugs which are used in angina, these include nitrates, calcium channel blockers, beta blockers, and potassium channel openers. These are the four main group of drugs which we can use in angina. We will discuss these one by one, starting from nitrates.
First of all, how nitrates work. Nitrates, they act by releasing nitric oxide. Nitric oxide, it stimulates an enzyme called as guanylate cyclase. And we know guanylate cyclase, it results in formation of cyclic GMP. Cyclic gene. And this cyclic GMP, it will activate a protein kinase known as protein kinase G. Cyclic GMP activates protein kinase G, and this protein kinase G, it inhibits the action of myosin light chain kinase. Myosin light chain kinase is required for smooth muscle contraction. So when this is inhibited, there will be smooth muscle relaxation, which result in vasodilation. So nitrates release NO, NO increase cyclic GMP, and cyclic GMP will finally result in vasodilation by inhibiting the smooth muscle of the blood vessels. Now important thing, nitrates predominantly dilate veins. Predominantly dilate veins. Very little dilatation of arteries. So because they mainly dilate veins, so their principal action is to reduce the preload. So the main mechanism of action of nitrates in classical angina is a reduction in preload. However, because they are causing dilation of arteries also, although it is much less, but this dilatation of arteries, it is required in variant angina. So read carefully. If they ask mechanism of action of nitrates in classical angina, the answer will be decrease in preload. But if they ask the action, mechanism of action in variant angina, then the answer should be dilatation of coronary artery. Remember, no other answer is possible in variant angina. So nitrate can dilate coronary artery also. Now the question comes, why nitrate mainly dilate veins and not dilating artery too much? The reason we discussed earlier also, nitrates, they must be metabolized to generate nitric oxide. Only then the action will come. And this metabolism to nitric oxide is done by an enzyme called as aldehyde dehydrogenase. Aldehyde dehydrogenase, and this aldehyde dehydrogenase enzyme is more in the veins and less in the arteries. That's why nitrates primarily dilate veins, because more NO is generated in the veins and less is generated in the arteries. Second important thing to remember, this aldehyde dehydrogenase, it may be present at two places, either in the cytoplasm or in the mitochondria. So aldehyde dehydrogenase may be present in cytoplasm or mitochondria. Almost all the nitrates, they are activated by cytoplasmic aldehyde dehydrogenase. Whereas glyceryl trinitrate, which is the main nitrate we all know, glyceryl trinitrate or nitroglycerin, it is activated by mitochondrial aldehyde dehydrogenase. All the nitrates are activated by cytoplasmic, whereas nitroglycerin by mitochondrial aldehyde dehydrogenase.
Now the drugs in this category, we have glyceryl trinitrate, also called as nitroglycerin, glyceryl trinitrate or nitroglycerin. The other drug is isosorbide dinitrate. Another nitrate is isosorbide mononitrate. Short form we can write IMN, isosorbide mononitrate. Then we have pentaerythritol tetranitrate. Pentaerythritol tetranitrate. And one more we have is amyl nitrite. These are the main nitrates we have. Important point regarding these nitrates to remember. So first of all, as we discussed in general pharmacology, nitroglycerin is having very high first pass metabolism. So to avoid that problem, we like to use this drug by sublingual route, and this is true for first two nitrates. So nitroglycerin and isosorbide dinitrate, they are given by sublingual route, and they are drug of choice for acute attack of angina by this route. Another question asked is, all the nitrates have high first pass metabolism. Which nitrate has minimum first pass metabolism? Minimum first pass metabolism is noted in isosorbide mononitrate. Isosorbide mononitrate has minimum first pass metabolism, and this you can remember in Hindi from the name of this drug. It is written as IMN, isosorbide mononitrate, and in Hindi you can study this as इसका metabolism नहीं होता. इसका metabolism नहीं होता. So that means it has minimum first pass metabolism. Another important question asked in the nitrates is, which is the longest acting nitrate and which is the shortest acting nitrate? You can very easily remember this. Longest acting nitrate has longest name and shortest acting nitrate has shortest name. The longest acting is thus penta-erythritol tetranitrate. It is having longest name. Whereas shortest acting is amyl nitrite. It has shortest name. Another important thing, in the nitrates, there is a very important concept which is called as nitrate free period. What happens is, if we give a nitrate, it will cause vasodilation that will protect from angina. Suppose we want to give nitrate for long periods to prevent angina. Nitrates will stop producing its beneficial effect if they are given continuously for long periods. So that means the tolerance occur to nitrates if they are continuously present in blood. So to prevent the tolerance, what we have to do is we have to give minimum 6 to 8 hour periods every day, continuous 6 to 8 hour period when nitrates are not present in the blood. So that period is called as nitrate free period. Like suppose a nitrate is working for 6 hours. So normally if a drug works for 6 hours, we usually give after every 6 hours. That means we give morning tablet, then afternoon, then evening, then night. But if we use nitrate in this manner, we give after every 6 hours. Because they are present continuously in the blood, it will lead to tolerance. So that means in spite of presence in the blood, they will stop protecting from angina. So then this will be a waste of giving nitrate. So we do not want this. So what we do is we have to give nitrate free period. So we will skip one tablet. Suppose we skip the night tablet. So we will give morning, afternoon and evening tablet. So when nitrate is not present in tablet at night is not given, they are not continuously present in the blood. So tolerance do not occur. So in case of nitrates, we have to give nitrate free period. Like what we commonly advise is when nitrates are given as transdermal patch. So what we do is we ask the person to remove the patch at night and again apply in the morning so that we get a nitrate free period. There is one very important drug interaction with nitrate which is important to remember. So first of all we'll see nitrates. They act by releasing nitric oxide. Nitric oxide increase cyclic GMP. Cyclic GMP cause vasodilation. Now we know that cyclic AMP and cyclic GMP, they are normally metabolized by phosphodiesterase enzyme. Phosphodiesterase enzyme. So if a person is taking nitrate for angina and we give him another drug which inhibit phosphodiesterase, the example is sildenafil, the drug used for erectile dysfunction or impotence. So if a person is taking nitrate for angina and the person takes sildenafil, then what will happen is nitrate increase cyclic GMP and sildenafil will inhibit the metabolism of cyclic GMP. So that will lead to very high levels of cyclic GMP that result in very severe vasodilation. and that extensive vasodilation will be responsible for very severe hypotension. So person will develop severe hypotension. So it is very important that nitrates should not be combined with sildenafil, otherwise severe hypotension can occur. Yeah, so this is very important drug interaction with nitrates.
Now we can discuss other uses of nitrates. So the uses of nitrates you can remember from the mnemonic A, B, C, D, E and F. So A we just discussed, A for angina. So nitrates are used in angina. In classical angina, their main mechanism is decrease in preload. In variant angina, their main mechanism is dilation of coronary artery. Then B for biliary colic. Remember, nitrates cause smooth muscle relaxation. They not only cause vasodilation, but they also relax the smooth muscle at other places also. So by relaxing the smooth muscle of the bile duct, they are useful in biliary colic. But be very careful. Clinically, it has been found that nitrates are not effective in renal colic. They are used in biliary colic. Then C for cyanide poisoning. First of all, we'll see how cyanide poisoning occurs. There is an enzyme which is known as cytochrome oxidase. This is the enzyme involved in a respiratory chain, electron transport chain, or in simple language if we assume, this is involved in generation of energy. It produces ATP for the body. Yeah. Now cytochrome oxidase, whenever cyanide is produced, cyanide, it bind to cytochrome oxidase, and when it bind to cytochrome oxidase cannot do its work, so that means body become energyless. So in the treatment of cyanide poisoning, our main aim is to make cytochrome oxidase free from cyanide. So how we can do so? So we can do so by sending a very good friend of cyanide, so that cyanide leaves cytochrome oxidase and start talking to that friend. And the name of such a friend is methemoglobin. So methemoglobin is a very good friend of cyanide. So whenever methemoglobin comes, the cyanide will leave cytochrome oxidase and bind to methemoglobin. But we thought that when hemoglobin is already present in the body, then why to give methemoglobin from outside? We can try to convert that hemoglobin to methemoglobin. So that is done by nitrites. So hemoglobin to methemoglobin, it is done by amyl nitrite or sodium nitrite. So they convert hemoglobin to methemoglobin, and now this methemoglobin, it will bind to cyanide, and cyanide will be dissociated from cytochrome oxidase and it will start working. Clear? The poisoning is reversed. The problem is the cyanide which bind to methemoglobin, it will convert methemoglobin into cyan methemoglobin. And cyan methemoglobin is itself very toxic. So although we have treated one toxicity, cytochrome oxidase has started working, but the intermediate produced cyan methemoglobin can also cause toxicity. So now we want to remove this metabolite also. So what we do, we give another drug which is called as sodium thiosulfate. Sodium thiosulfate. So what it does is, it will exchange its sulfate group with the cyanide group. So that means the cyanide from the methemoglobin, it is removed and the compound formed is sodium thiocyanate. So sulfate is exchanged with the cyanide. So thiosulfate is converted to thiocyanate, and thiocyanate is water soluble and it can be easily excreted by kidney. So revising what we have discussed is, hemoglobin is converted to methemoglobin by amyl nitrite. Methemoglobin will remove cyanide from cytochrome oxidase and is converted into cyan methemoglobin. Cyan methemoglobin is itself toxic, so we give sodium thiosulfate, which will remove the cyanide from the methemoglobin and make it detoxified, and sodium thiocyanate formed can be excreted. So for treatment of cyanide poisoning, we give amyl nitrite plus sodium thiosulfate. Clear? Now amyl nitrite is given by inhalational route for this purpose. then we thought that amyl nitrite is producing an intermediate which is itself toxic. So if we send some other friend of cyanide which can remove cyanide from cytochrome oxidase but do not cause problem, that will be better. So we developed another antidote for cyanide poisoning which is called as hydroxocobalamin. Hydroxocobalamin is also a very good friend of cyanide. So when we give hydroxocobalamin, it binds to cyanide and is converted into cyanocobalamin. So cytochrome oxidase is free of cyanide, it will start working, poisoning is reversed. But what is hydroxocobalamin? Yes, it is vitamin B12. And what is cyanocobalamin? This is also vitamin B12. So one form of vitamin B12 is converted into another form of vitamin B12, and we have treated the toxicity also. So we have no problem of intermediate also. So hydroxocobalamin is now the drug of choice for cyanide poisoning. It is antidote of choice for cyanide poisoning because there is no problem of intermediate toxicity, and hydroxocobalamin is given by intravenous route. Remember, amyl nitrite is given by inhalational route and hydroxocobalamin is given by intravenous route. Okay. So this is cyanide poisoning. Then D means dil ka dora. In Hindi you can remember dil ka dora. Dil ka dora means myocardial infarction. So nitrates can be used for MI also. We will discuss later on in myocardial infarction. Then E means esophageal spasm. Esophageal spasm. So nitrates, they will relax the esophagus also. So when there is esophageal spasm, it can relax that and treat the spasm. And lastly, F means failure. Failure means heart failure, congestive heart failure. So we already discussed in CHF, nitrates are effective in congestive heart failure. They decrease the preload. Okay. So these are the important uses of nitrates.
So this is about the first group of drugs in angina, that is nitrates. So we have covered first group of drugs, nitrates. Now moving to second group of drug, calcium channel blockers. Now we have many types of calcium channels in the body. Two main types you need to remember. One are called L-type calcium channels. Second are called T-type calcium channels. Two type of calcium channels, L-type and T-type. L-type calcium channels are mainly present in cardiovascular system, and T-type calcium channels are mainly present in T for thalamus. You can remember they are present mainly in central nervous system. Although L-type means long lasting, T for transient, but you can remember T for thalamus. So in cardiovascular system, wherever we study calcium channels, they are mainly L-types, whereas in CNS we will study about T-type calcium channels. So in angina we use calcium channel blockers, so we will use L-type calcium channel blockers. So second group of drugs in angina, they are calcium channel blockers. And we have three main drugs in this category. One is verapamil. Second is diltiazem. And third is a chemical group known as dihydropyridines. Dihydropyridines. It is a group of drugs, dihydropyridines. We have many drugs in this group. So all of them end with dipin. So any drug whose name end with dipin belong to this category. Examples like nifedipine, amlodipine, nicardipine, clevidipine, and many drugs. So dipins. So three type of calcium channel blockers we have are verapamil, diltiazem, and drugs ending with the dipins. So we'll discuss the important difference between these calcium channel blockers by noting their effect on blood vessels and heart. So their effect on blood vessels and blood pressure, and their effect on heart rate. Now all the calcium channel blockers, verapamil, diltiazem as well as dihydropyridines, they block calcium channels in the blood vessels. And when we block calcium channel in the blood vessel, that will lead to vasodilation. So all the three drugs are causing vasodilation. And vasodilation will result in decrease in BP. Which blood pressure will be decreased mainly by vasodilation? They will mainly decrease diastolic blood pressure. So due to vasodilation, diastolic BP decreases. So calcium channel blocker decrease the diastolic blood pressure. Now effect of these drugs on heart. We discussed earlier also, whenever we discussed effect of any drug on heart rate, we discussed under two headings. One, direct effect of the drug. Second, compensatory response of the body or indirect effect. And we know that these drugs block the calcium channel in the heart. So the direct effect will be to decrease heart rate. Calcium is stimulatory. So when we block calcium channel, heart rate should decrease. And verapamil is a very strong calcium channel blocker in the heart. So in case of verapamil, we will make 3 arrows. So it is a very strong blocker. So severe decrease in heart rate. Diltiazem also block calcium channels in the heart, but it is less stronger than verapamil. So it also decrease heart rate, but less than verapamil. Now dihydropyridines, the special point is they do not block calcium channel in the heart. Dihydropyridines block calcium channel in the blood vessel, but they have no effect on heart. So that means they have no direct effect on heart rate. Yeah, so verapamil and diltiazem decrease heart rate by direct action. Dipins have no effect by direct action. Now the compensatory response, as we discussed earlier in our chapter on autonomic nervous system, compensatory response is opposite to diastolic blood pressure. So all the three drugs decrease diastolic blood pressure. So indirect effect or compensatory response of the body will be to increase sympathetic activity. So all the three drugs will tend to increase the heart rate. So if we see the net effect of these drugs on heart rate, the final effect on heart rate, it will be sum of these two activities. So the final effect on the heart rate is verapamil decrease the heart rate. Diltiazem also decrease the heart rate, but dipins increase the heart rate. So verapamil and diltiazem decrease the heart rate and dihydropyridines increase the heart rate. So if we discuss the effect of calcium channel blockers in angina, we can find that mechanism of action of verapamil and diltiazem in angina, they cause vasodilation that will decrease preload and afterload. And they also decrease heart rate, which further decrease the work of the heart. So all the three methods are important in angina: decrease preload, afterload, and decrease heart rate. But in case of dihydropyridines, if you see carefully, one method is useful in angina. That means they decrease preload and afterload. But by increasing heart rate, they can precipitate angina. They can worsen angina. So the final effect of dipins will depend upon balance of these two actions. That means if vasodilatory effect is more, they are useful in angina. But if tachycardiac effect is more, they can worsen angina. So preferably we should avoid calcium channel blockers in angina, particularly dipins category. Verapamil and diltiazem are useful, but dihydropyridine type of calcium channel blockers should be avoided in angina.
The fast-acting calcium channel blockers like nifedipine or clevidipine, they suddenly cause vasodilation, and that will lead to very severe tachycardia because the reflex will be strong when suddenly the BP falls. So they cause severe tachycardia, very severe tachycardia, and this tachycardia is much more than the preload and afterload reduction which occurs due to vasodilation. So these will precipitate angina. So nifedipine or clevidipine like drugs we will never use in angina. On the other hand, the long acting drugs like amlodipine and even nicardipine, they will gradually slowly decrease the cause the vasodilation. And when vasodilation occurs slowly, then the reflex will not be that much. So tachycardia causing potential is very less. So they may be used in angina. So basically calcium channel blockers, if we see the mechanism of action in angina, in classical angina particularly, they can decrease preload, they can decrease afterload. Although they cause tachycardia which can be harmful, but long acting calcium channel blockers, dipin group of drugs, they cause lesser tachycardia. Verapamil and diltiazem, they cause decrease in heart rate also. So in classical angina, the mechanism of calcium channel blockers non-DHP, that means verapamil and diltiazem, they decrease preload and afterload as well as decrease heart rate. But in case of DHP, we normally avoid in angina because they can cause tachycardia. But if they ask mechanism of action of calcium channel blockers in variant angina, then only one thing is possible, and that is dilatation of coronary artery. Calcium channel blockers can dilate coronary artery, so they can be used in variant angina. In fact, calcium channel blockers are the only drugs which can decrease mortality in variant angina. So they are drug of choice in prophylaxis of variant angina. They can decrease mortality. Clear? Now coming to adverse effects of calcium channel blockers. The important adverse effect you need to remember: one, by causing vasodilation, they can cause headache. Any drug which dilate the blood vessels in the brain can cause headache. So calcium channel blockers can cause headache. Second, calcium channel blockers, they can cause constipation. So remember, most of the drugs cause diarrhea as a side effect in the GIT, but calcium channel blockers cause constipation as a side effect. And third important side effect is gum hypertrophy. So important adverse effects of calcium channel blockers to remember are headache, constipation, and gum hypertrophy. Now we will move to special points regarding the individual drugs. As already discussed, nifedipine and clevidipine, they are very fast acting and short acting drugs. So they cause severe tachycardia. Whereas amlodipine and nicardipine, they are very long acting drugs. Then nimodipine is a drug which is called as cerebroselective calcium channel blocker. Cerebroselective calcium channel blocker, what do we mean is, it will block the calcium channel mainly in the blood vessels of brain. Remember, it is also a peripheral calcium channel blocker because the name ends with the dipine. But peripheral does not mean that it do not go to brain. Peripheral means it do not work on heart. So nimodipine, it blocks the calcium channel only in the brain. So it is used for subarachnoid hemorrhage. So which calcium channel blocker is indicated in subarachnoid hemorrhage? It is nimodipine. Then there is one drug called as clenidipine. Clenidipine, like all the dipines, it also block L-type calcium channels. But special point to remember is, this has the property to also block N-type calcium channels. So which calcium channel blocker can block both L-type as well as N-type calcium channels? It is clenidipine. Okay.
So these are the effect of calcium channel blockers in angina. So we covered nitrates and calcium channel blockers in angina. Third group of drugs we'll cover in angina are potassium channel openers. And the drug we use is nicorandil. Nicorandil. Now nicorandil is a drug which has dual action. Dual action means it not only opens the potassium channel, but it also acts by releasing nitric oxide. And both of these actions are written in the name itself. You can remember from the name itself, these remembered as N for nitric, O for oxide, R for releaser. The name says it will release nitric oxide releaser. Now we will write the name of nicorandil again, but if we write the name like this, NiCO, so it look like KO, that means potassium opener. So nicorandil name says it is nitric oxide releaser as well as potassium channel opener, and it is used for dil ka dard, that means angina. So used for angina. Now the three drugs we have discussed so far in angina: nitrates, potassium channel openers, and calcium channel blockers. All the three drugs act by causing vasodilation. So they can dilate the coronary artery also. So they are used in both classical as well as variant angina. But on the other hand, the last drug we are going to discuss, which are beta blockers. First of all, what is the mechanism of beta blockers in angina? So very simple mechanism, beta 1 increase heart rate. So when we block beta 1, heart rate will decrease. And when heart rate decreases, the work decreases. So when the work decreases, which angina can be treated? Yes, it is classical angina. So beta blockers are used in classical angina by decreasing the heart rate. But very important to remember, beta blockers, can we use them in variant angina? What we want in variant angina? We want to dilate the coronary artery. And which beta receptor is present on coronary artery? Yes, it is beta 2. Remember, we have one heart and everywhere else we have beta 2 receptors. So beta 2 receptor, the effect on coronary artery is to cause vasodilation. So if we give a beta blocker, they will rather cause vasoconstriction. And by causing vasoconstriction, they can worsen the variant angina. So beta blockers are contraindicated in variant angina. Remember, other drugs can be used in both classical and variant angina, but beta blockers are indicated only in classical angina. They are contraindicated in variant angina. Now we will move to some new drugs in angina. New drugs for angina. And among the new drugs, first of all, we'll discuss a drug called as bradycardic agent. Bradycardic agent. The name of the drug is ivabradine. Ivabradine. Now, to understand the mechanism of this drug, in the heart, particularly in the SA node, we have a special type of sodium channel. And this sodium channel carries a current. Remember, any channel whenever opens, the ions move. And when the ions move, it will lead to generation of current. And the current which is generated due to this sodium channel is called funny current. Funny current, which is abbreviated as I, which is symbol of current, and F for funny. Funny current. Now what is so funny in this? Actually, what happens is, normally sodium channels open when there is depolarization. But this is a special type of sodium channel which open during hyperpolarization. So funny current is simply named because the channel opens during hyperpolarization. And this sodium channel is used to maintain the heart rate. So if we block this sodium channel, ivabradine block this sodium channel. So ivabradine, by blocking this funny current, will decrease heart rate. That's why it is called bradycardic agent. So heart rate will decrease. So by decreasing the heart rate, work of heart decreases. So it is useful for angina. So ivabradine is called bradycardic agent. Decrease the heart rate, and by decreasing the heart rate, decrease the work of heart. So that is useful in angina. Main side effect of ivabradine is it causes decrease in visual acuity. Visual problems are the main side effect of ivabradine. Visual acuity is reduced. And all the things which we have discussed in ivabradine, it can be remembered from the name itself. So its name starts with I. I will say that it is IF blocker. That means funny current blocker. Next two letters VA, they say that it affects the visual acuity. Visual acuity. Next letters brady, they says that it is a bradycardic agent. Mechanism is to cause bradycardia. Now recently, ivabradine has also been approved in congestive heart failure. Congestive heart failure. As it is causing decrease in heart rate, it decreases the work of heart. So that is beneficial in congestive heart failure also. So this is about first drug, bradycardic agent. Second group of new drugs, we have developed a new group which is called as Rho kinase inhibitor. Rho kinase is an enzyme which by indirect methods, by activating many enzymes, it results in vasoconstriction. So the final effect of Rho kinase is to cause vasoconstriction. So if a drug inhibits this, it will result in vasodilation. And vasodilation we already discussed is useful in angina. So the drug inhibiting Rho kinase can be used in angina, and the drug which act by this mechanism is Fasudil. Fasudil is a Rho kinase inhibitor indicated in angina.
Nitarsudil, it is another Rho kinase inhibitor. Just like we discussed Fasudil, its name also end with Sudil. So Fasudil, Nitarsudil. So this is also a Rho kinase inhibitor, but this is approved in treatment of glaucoma. Nitarsudil, it is a new Rho kinase inhibitor. It is approved for glaucoma, whereas Fasudil is used in angina.
Now, third and very important group of new drugs is metabolic modulators. Metabolic modulators. Now, before going to this group of drugs, we'll try to understand some basic things. What is the problem in a patient of angina? There is less blood supply to heart. The question is, why blood is required by heart? It is required for carrying the oxygen. The question is, why oxygen is required? Oxygen is required to metabolize these substances to generate energy. So those substances are called fuel. So oxygen metabolizes the fuel to generate energy, and that energy is used to do the work. So blood is required for producing the energy by metabolizing the fuel. Normally, most of the body parts, they use glucose as the fuel. So oxygen will metabolize the glucose to generate energy. That means ATP. Now, what is the fuel for heart? Yes, the fuel for heart is fatty acids. Heart utilize fatty acids as the fuel. So oxygen will metabolize the fatty acid to generate ATP, energy. Now, difference between glucose and fatty acid as fuels are, glucose is a very good fuel, but fatty acids are not very good fuels. The meaning of this is, if we want to generate 100 ATP, glucose will consume 100 molecules of oxygen to generate that energy. But fatty acid require more amount of oxygen, hypothetically assuming 200 oxygen. So that means for generating same amount of energy, fatty acid consume more oxygen as compared to glucose. So if heart start utilizing glucose instead of fatty acids, then less amount of oxygen will become sufficient. So that means even if less blood is coming, it will result in generation of sufficient energy. So how we can do so is, we can give drugs which inhibit fatty acid metabolism. So if heart is not able to utilize fatty acids, then it will start utilizing glucose, and that will result in treatment of angina. So this mechanism is called as metabolic modulation. So we are modulating the metabolism and shifting the metabolism of heart from fatty acid to glucose, so that less amount of oxygen becomes sufficient. So the drugs which act by this mechanism are trimetazidine and ranolazine. Trimetazidine and ranolazine, and from the name you can remember, trimetazidine, the name itself say metabolic modulator. And the second drug, ranolazine, recently it has been found that it can also act by blocking the sodium channels. It affects the fatty acid metabolism, but it also acts by inhibiting the sodium channels. So these are the new drugs used in angina.
Now we will discuss a phenomenon called as coronary steal phenomenon. Now to understand this phenomenon, first we will discuss a basic thing. Suppose this is some portion of the heart which is supplied by coronary artery. This is main coronary artery. Coronary artery divide in branches, which further divide in branches. In most of the patient of classical angina, there is obstruction in the small branches of coronary artery. Small branches of coronary artery. So the blood which is in this area is receiving, it decreases. So this lead to ischemia in this area, and that is the main cause of problem in angina. But the problem is obstruction is present always 24 hours. But patient of angina do not have pain 24 hours. Then why it is so? The reason is our body has compensatory ability for everything. That means whenever the ischemia occurs here, there is compensatory vasodilation. So that means due to ischemia, this blood vessel, this will dilate. This blood vessel dilate, and it can, dilatation is so much that the effective diameter through which blood is going just become equal to a normal blood vessel. So it can receive the same amount of blood which a normal vessel is receiving. So this person do not develop any pain. Then we developed a drug called dipyridamole. Dipyridamole. This is a drug which dilate only small vessels. We have problem in small vessels. So we developed a drug which dilate only small vessels, thinking that it will be a very good drug for angina. But when we give dipyridamole, instead of decreasing the attacks of angina, the person started having more attacks of angina. Then the cause was searched, and it was found that it is dilating the small vessels only. So when we give dipyridamole, will it be able to dilate this vessel? Obviously not, because it is a large vessel. Similarly, it cannot dilate this vessel, but it can dilate this vessel. It is a small vessel. So when we give dipyridamole, dipyridamole lead to dilatation of the small vessel. So that means this vessel is dilated. So this vessel is remains same, but this vessel dilates. This vessel dilates. But dipyridamole try to dilate this vessel also. This is also small vessel, but it cannot be dilated because it is already dilated. Due to obstruction, it is already dilated. So what is the net effect of dipyridamole is, if 100 ml of blood is coming in this area, normally 50 ml was going to this area and 50 was going to this area. But on giving dipyridamole, the normal area become dilated, the ischemic area remains same. So more blood start going here and less blood comes here. So that means some of the blood from the ischemic area is stolen and given to normal area. That's why this is called coronary steal. Coronary steal. Coronary steal means blood is stolen from the ischemic area and given to normal area. So that lead to increase in attacks of angina because ischemic area become more ischemic. You must have heard about Robin Hood. So what does he do? Robin Hood steals the money from the rich people and give it to the poor people. So what is happening in the coronary state? Opposite is happening. That means the blood is stolen from the poor people, means ischemic area, and given to the normal person, that means rich person. So coronary steal, it is also known as reverse Robin Hood phenomenon. Another name of coronary steal is reverse Robin Hood phenomenon. Okay, so that means any drug which dilate only small vessels can show the phenomenon of coronary steal phenomenon. And these drugs you can remember from the mnemonic hide, and you can logically think that if a person has stolen something, he will hide that thing. So the drugs are hide, H for hydralazine, I is isoflurane, D is dipyridamole, and E is enflurane. So these are the main drugs causing coronary steal phenomenon. Beta blockers, they are found to cause Robin Hood phenomenon. It has been found that beta blockers, they increase the blood flow to the ischemic area as compared to non-ischemic area. So it is known as Robin Hood phenomenon.
Now related to angina, the another topic is myocardial infarction. Now what is the difference between angina and myocardial infarction? Angina is called myocardial ischemia and MI is called myocardial infarction. And we know ischemia is reversible, infarction is irreversible. Basically, in angina, if the blood supply is restored, the heart tissue survives. Whereas in myocardial infarction, the heart tissue is already dead. So that means even on restoration of blood supply, that area cannot work again. So in myocardial infarction, for treatment purpose, we divide it on the basis of ECG finding into two types. One is called as non-ST elevation MI. So if in the ECG, ST segment is not elevated. And second is called ST elevation MI. ECG, ST segment is elevated. Now for treatment of non-STEMI, we give Mona to this person. Treatment of non-STEMI is Mona. Mona stands for morphine, oxygen, nitrates and aspirin. Morphine, oxygen, nitrates and aspirin, they are used in management of non-STEMI. But on the other hand, in the management of STEMI, if you see the STEMI says ST elevation. ST elevation. So ST elevation look like standard is elevated. So this person's standard is elevated. So this person will require something else. Only Mona will not be able to manage. So this person, instead of we will give Mona, we will give Sonam to this person. Now if you see carefully, the name of Sonam itself contains Mona. M-O-N-A. That means morphine, oxygen, nitrate and aspirin. That means 4 drugs are same. One drug is extra and that S stand for streptokinase. Streptokinase group of drugs which are called thrombolytic drugs. They are indicated only in STEMI. Remember, STEMI, streptokinase is the group of drugs indicated only in ST elevation MI. They are not indicated in non-ST elevation MI. That is the most important point you need to remember. Thrombolytic drugs are indicated only for STEMI.